Um, we're going to talk about weaning from mechanical ventilation in the LTACH setting, um, which is a little different than the acute care setting. So we'll go through some things. Um, this is just the Whittier Nursing Education saying that you're going to get one contact hour for this program. Um, this program will emphasize on weaning from mechanical ventilation and eventually liberating from the ventilator. Um, we're going to look at a couple of things. We'll look at the primary cause of ventilatory dependence, the readiness to wean from the ventilator, and some strategies that we can use to successfully liberate patients from mechanical ventilation. Of course, um, medicine is not an exact science, so we do try to do um, practice, do evidence-based practice and scientific-based practice. But as those of us know, working in healthcare, it's not an exact science. So some things are, you just have to tweak some things. So we'll go through that. After completion of this program, you will be able to describe two techniques that are used in weaning from mechanical ventilation, be able to list three indicators that the patient is ready to wean from mechanical ventilation, and you'll be able to understand that weaning from mechanical ventilation covers the entire process of liberating the patient from mechanical support. And it can be a process, and sometimes a slow one. So first, we're going to assess the readiness to wean the patient. Um, the first thing you want to do is ensure that the underlying cause of vent dependence is resolved and that etiology for respiratory failure has improved or resolved. There's a whole plethora of reasons why people can go into respiratory failure. Some are included here, but it's not limited to these things. Um, so we have to make sure that um, the the underlying cause is resolved. So, say if somebody has bacterial, viral, fungal infection or a septicemia, that has to be resolved before any attempts at weaning off of a ventilator um, can be attempted. If it's a neurological disorders, there are some that um, our patients are able to wean from, and some that are not. Um, the ones that are not, such as ALS, that's a progressive neurological disorder. If somebody is on a vent because of that disorder, it's just going to progress. We're not going to be able to wean them. Something like myasthenia gravis or Guillain-Barré syndrome, those things are reversible, and we can successfully wean them off of a vent. If it was a code event, those patients, as they get better, they can also be liberated from ventilation. But it's important to clear all those things up before we can even think about that. Um, you want to also make sure that the patient is hemodynamically stable with low or no medications. So that's an important one because when you wean somebody off of the ventilator, they have to be hemodynamically stable before you can do so because they're going to be working harder. You don't want them to be unstable right from the get-go because you don't want them to. We're not setting them up to fail weaning. We're setting them up to be successful. So if there's any kind of hemodynamic instability, we have to um, fix that first. Um, this is one, the patient must be awake, alert, and easily arousable. Um, this is a tricky one because a lot of times patients are on medications that affect wakefulness. Um, and, it's one of those fine lines where if they're anxious, you want to give them something to take the edge off, but you don't want to um, depress their drive to breathe. So, should probably discontinue any medications that cause sleepiness or anything like that before weaning trials are started. Um, Anxiolytics, like such as Ativan and Xanax and things like that, should be used with caution and only if necessary. Um, because again, those kind of medications will depress your drive to breathe, and then it can set the patient up for failure. Um, Sometimes patients do struggle in the beginning of weaning. So yes, they probably need something to take the edge off. But I would say use those things cautiously. And that would be up to the pulmonologist or the primary provider to decide how they're going to use those medications when a patient is weaning. The patient must also have the ability to initiate an inspiratory effort. So they're on the ventilator and their respiratory rate, the vent rate is set at 14, but you notice that every breath the patient's breathing, they're going to get 20, they're taking 20 breaths. So they're able to initiate an inspiratory effort because they're breathing above the set rate on the ventilator. So once you see that, you can see that the patient has the ability to breathe spontaneously. Even though when they're on the ventilator, every breath they're getting is going to be a mandatory breath, but they are making that inspiratory effort. So that's a good indicator to know that the patient is ready to start weaning. And then lastly, I'll talk about, as far as readiness to wean, the nutritional status of the patient. Usually malnourishment occurs in ventilated patients. They're in the ICUs for a long time. They become, they're on tube feeds or what have you, or maybe not, maybe just IVs. And so it's very common for them to become malnourished. So your dietitian is a very instrumental team player when it comes to weaning from mechanical ventilation, because the patient is going to go now from not doing any work, the ventilator doing all the work for the patient, to now the patient needs to do some work, use their diaphragm, get their diaphragm stronger. It's kind of like you decide you're going to go to the gym. So what do you do when you decide you consistently make an effort to go to the gym every day? You're going to change your nutritional habits because you want to be stronger and you want to get stronger. And you're burning more calories. You're using those muscles you haven't used before. Well, the same thing goes for patients who are bedridden and on a ventilator. Now they have to learn to reuse their diaphragm to breathe spontaneously. And in order to do that, they need the proper nutrition and the proper nutrition to do that and to increase their ability to strengthen that muscle. All right. So some of the strategies that we tend to use at Whittier, I'll speak for Whittier in Westborough because that's where I work. We usually start off with a pressure support mode of ventilation. This is a mode of ventilation on the ventilator, which is often used to assist patients with spontaneous breathing efforts. The pressure support augments a patient's spontaneous effort by providing a positive pressure during the inspiratory phase. It works in conjunction with the patient's respiratory drive to decrease the work of breathing and improve ventilation. So what happens is when the patient initiates a breath, the ventilator responds by delivering a predetermined pressure support level for a set duration. When the patient exhales, the pressure is reduced to the lower expiratory pressure, allowing for passive exhalation. This is a very common mode used in starting to wean. Typically, when patients come, they usually come from the ICU to the LTACH, and they're usually on a controlled form of ventilation. Or sometimes what I like to see when I review a patient for our facility is for them to be already weaning in the pressure support mode, or at least be doing some spontaneous breathing. So that kind of explains that a little bit for the pressure support mode. Here's how we kind of go about it. It's kind of it's not a set science, a set protocol, but usually the RT will start with pressure support ventilation during the daytime, returning the patient to assist control ventilation to rest the patient at night. So during the daytime, the patient is doing most of the work on the ventilator, and at night, the ventilator takes over and the patient is resting. We do this for the first few days. Again, I'm speaking for our Westborough facility. This technique, the very first one that I just talked about, is very patient specific, depending on their respiratory effort and fatigue while they're on the pressure support. Sometimes they can't tolerate the pressure support all day. Sometimes they can only tolerate it a couple of hours. It's all patient effort driven. So we look at that. After the patient is able to tolerate the pressure support during the day, the respiratory therapist will then move to utilizing pressure support mode around the clock, meaning during the day and at night, for a few days. Once the patient is able to tolerate that, then we can try trach mask trials. Now, that's not to say that we couldn't try to take a patient right from assist control ventilation, which is full vent support, and put them on a trach collar or a trach mask. That's something that can be done. That's also trial and error. That's one of those situations where it's sink or swim, or it's also sometimes the patient doesn't tolerate pressure support at all on the vent. And so in those cases, we would go right from being on the full support to a trach collar. And sometimes patients can go on a trach collar all day and need the vent support just at night. So those are a few common scenarios. It just depends how the pulmonologist wants to go about getting this situated with the patient. And everybody has different opinions about pressure support, trach collar, all of that. But anyways, when we go to the trach mask trials, that's basically we take the patient off the vent, put them on a mask that goes over, kind of sits at where their trach is. It's hooked up to a aerosol source, and they can get heated or cool aerosol. It can also provide oxygen, supplemental oxygen. This again is also patient specific in regards to how well a patient tolerates it. Like I said, some patients won't tolerate being on a trach collar for very long, and that's okay. You know, this isn't a race, and luckily, in the world of LTAC, we have 25 days or more to um, liberate the patient um, from the vent. So this isn't a race. We're not here to set the patient up to fail. We want the patient to succeed, and we're able to do that in this setting because it's the therapists have time to be able to spend with the patient doing these slow trials and things like that. Um, some other strategies for patients who have a really, really hard time, meaning they don't tolerate going from pressure support on the vent to going onto a trach collar. Usually this occurs because when you're on the vent, you have a set amount of PEEP. So your PEEP is it's a positive pressure that's on exhalation, at the end of exhalation, that holds the alveoli open. So when you take the patient off of the vent and place them on a trach collar, you're losing that PEEP. And some patients have a hard time with that because what happens then is the alveoli collapse and they're not able to oxygenate and they're not able to have good gas exchange. And so they don't tolerate it. So sometimes there's a couple of things we can do, and I'll just go over those a little bit. Um, One of the things is using high flow therapy. Um, this is usually used in uh, patients who have in the acute care. They're either impending respiratory failure or they're going to try this before they um, intubate them. It can be also used in the opposite, in the reverse way. Um, so the theory behind it is that you have a high flow system and it's able to give, say, 30, 40, 50 liters per minute of flow to that patient. Um, so this high flow that the patient is getting. So if you think about it, that the flow's going in and they're exhaling against that flow. So when they exhale against that high flow, it creates sort of a PEEP kind of. And so the theory is that PEEP, it helps them to wean a little bit better than they would just going from the ventilator to the trach mask. And then we can wean them further from the high flow to the trach mask, because in theory, what should happen is the patient should regain some element of physiologic PEEP um, when when they get stronger and they start to wean off the high flow. So that can be helpful for difficult weaning patients. And one of the other things that can be also useful is using a Passivhair valve in line with the ventilator. Again, a Passivhair valve is a speaking valve. It's a one-way valve. It usually works where the patient can take a breath in through their trach, and then the valve closes and they exhale through their upper airway. That allows air to pass through the vocal cords and allows them to speak. Well, when you use it in line with the ventilator, it also works in very much the same way, but it creates that closed system again where when they inhale, the ventilator is going to give them the breath. When they exhale, the valve's going to close and they're going to exhale through their upper airway. And that's going to help them to reestablish some physiologic PEEP, also improving gas exchange. It shows one study that I was looking at showed that the use of the speaking valve resulted in a reduced respiratory rate and a reduced end tidal CO2. I have not personally had that experience because we don't utilize end tidal CO2s right now here, but it's coming in the future. But I did see that in one of the studies, and I do actually believe that would be the case. Some other things we look at, we usually try to have a continuous pulse ox on the patient at the bedside. And we're always monitoring the patient. But what I want you guys to know is that sometimes numbers don't mean failure. So what I mean by that is, if you have a blood gas or you have a SAT that's low, but the patient looks and feels good, that doesn't necessarily mean, okay, the SAT's 88%, I better put them back on the ventilator. You have to look at the whole picture. Look at your scientific data, meaning lab work, x-rays, numbers, but also look at the patient. You could have a patient who has a perfect blood ABG, a perfect chemistries, a perfect SAT, but the patient's sitting in the bed and they're diaphragmatic breathing, they're working, their respiratory rate, is starting to go up. So you kind of have to look at both things and put the puzzle together as to when to know when the patient should go back on the ventilator. And again, they're trying to strengthen their diaphragm. So yes, they are going to get a little bit fatigued, but just like my analogy of going to the gym, the first couple of times you go to the gym, yes, your muscles are going to hurt. Yes, your muscles are going to be tired. But what happens? You are persistent and you go every day and you strengthen those muscles and they get stronger, and then you're able to do more, and so forth and so forth. And that's the same way with patients that are vent dependent. They haven't used those muscles. They've been laying in an ICU bed for who knows how long. So as the diaphragm gets stronger, they will be able to liberate from the vent, and yeah, so there's that. And then what else? These are my sources for information. And I guess I'm going to open it up to questions now. If anyone has any questions or anything you want to know.
Hi, Brian. I actually do have a question.
Hi, who's this?
This is Erica, one of the speech therapists.
Hi.
Hi. I'm curious, how much of the parameters for weaning and making decisions regarding use of trach mask versus use of just the nocturnal needs for the vent, like how much of that is dictated by the pulmonologist, and how much leeway do the respiratory therapists have in order to just make those decisions and try it out, depending on how the patient's doing?
So a lot of times, this is very, how do I answer this? So I think the therapists kind of make the decision and the determination. They like we do rounds every day with the pulmonologist. So there's always a discussion as to how the patient did or didn't do. And then hopefully the therapist will say, okay, well, I tried this and it worked, or I didn't try that and it didn't work. As far as like going from the, trach collar to the vent at night, that's something that the pulmonologist looks at, along with our suggestions, of course, but usually the pulmonologist will look at that and say yay or nay, whether they think they're strong enough to do that. So it's kind of one of those type of things. One of the things we're going to start doing is probably more ABGs, more just different ways to evaluate the patient a little better than we already are. Does that answer your question, Erica?
Yeah, it does. Thank you.
Okay, cool.
Brian, this is Lauren, the other speech therapist.
Hi.
I also have a question.
Yes.
I have yet to meet a pulmonologist that is for inline PMVs. With that being said, this isn't the only facility that I've worked in. So this isn't the only pulmonary group that I've worked with as well. And I have, like I said, I've yet in 20 years to meet a pulmonologist who is in favor of inline PMVs.
Yes. So to speak on that, I have also been in the field for 20 years, and I have also not met a willing pulmonologist to use an inline PMV. And I think part of it is probably a bit of a fear, because of course, the patient's on the vent, so the cuff is always up. So you have to remember that, I think the fear is that they're afraid they're going to leave the cuff up when they put the PMV in line. Which is that's validated. I understand that, but I think if there's enough education, and promoting it, I think it would be very helpful. Does that help? Or
yeah, I mean, maybe this is something you and I can discuss further at another time. I know
I'd love to.
Point probably 10 years ago or so, I had a representative from Passimere come in, and they gave an in-service, and we invited the pulmonologist, and of course none of them came to the in-service. But maybe this is something we can discuss further in terms of seeing what we can do, because of course it's a brand new group of pulmonologists at this point anyway.
Right.
In trying to at least trial this with some of our patients that may be appropriate.
Right. Cool.